there's one piece of advice that you would give to men when it comes to understanding, recognizing, or just sort of taking their own health into account, what would you say? Where should they start? What should every man at least do this?
Every man should go to their in their home or wherever they have access to a mirror and look at themselves, right?
Shit, mic drop.
Welcome to another episode of Sippin On Excellence. I'm Coach KJ, and I'm here with my man, my dude, Dr. Lionel Hunt. Lionel, pronounce it right.
Get it right, man. Get it right. No, this is a podcast where we talk about any and everything under the sun, from politics to medicine to just relationships.
Anything that's going to allow you to sip on just a little bit more excellence in life.
And not only that, man, we say the quiet parts out loud. I know we say that all the time here, but no filter, straight, no chaser.
No funnel.
Today, we got a special guest, y'all. A special guest. This brother here is pretty impressive, and we'll let him tell his story in a minute. But Doc MJ is what he is affectionately known as.
This is true. This is true.
And there's a reason why.
This is true.
Doc, welcome, man.
What's happening? What's happening, man?
Man, I can't call it, man.
I appreciate you having me.
I know this cat. We both worked together at Cedars-Sinai Medical Center in LA. And I remember, I'm a little older than this cat, but somebody told me there's this hotshot cardiologist rolling around here, puffing his chest out. Okay. Right? And I'm like, and then I meet him one day on the bridge. I think he was on the bridge that day going over by where your office is. And I was like, this brother's actually kind of cool. And there's, there's not very many of us rolling around that campus.
Very true.
And one thing I'll say is that there's people out there who will speak, and there's people out there who will talk to you. Mm-hmm. Mm-hmm. He's a brother that'll talk to you.
I like this intro, yo.
He said, "This is okay. I got this.
You know what I mean? And
I got this."
And that's what, because there's people who are professionals who.
You said
once
this. You said professional like this.
Like this, professionals.
Oh, okay.
There's people who are professionals. there's people who are professionals that when we see somebody else, regardless of what they do, if they look like us, you don't get that nod.
Get the nod.
You get
Absolutely.
that recognition.
Absolutely.
But what I've noticed, there are people who are in our profession who will walk by you and just look at you like this. Mm-hmm. And if you make eye contact with me, regardless of what you look like, I'm going to give you a nod. Because that's just mutual respect for you being a human being.
Right.
And so to come across somebody who's accomplished in their own right, who will have a conversation, that means a lot, and that's
just grown ass men hanging out, having a conversation.
Yeah.
That's it.
Exactly.
And acting like it.
Doc,
not acting like it.
Tell us a little bit about yourself, man, so they know. I know, but so they know.
Yeah.
Your background, where you're from, and then we're going to dive deep into just life in a minute.
For sure, man. Well, again, I appreciate y'all having me. It's always great to be able to come around like-minded individuals and really just spread joy and the camaraderie that, isn't often spread amongst us. So I appreciate y'all bringing me in to share it with y'all.
Yeah.
Yeah, man. Dr. Merije Chukumerije, Dr. MJ is what I go by.
I'm going to need you to slow that down. Y'all catch that?
Merije Chukumerije. It's really easy if you just go ahead and slow it down. You know what I mean?
That's what
my first name is named after my last name, right? Mm-hmm. So once you get one of them, you 50% there. But yeah, man, I'm from Los Angeles, California. Grew up out here. Ended up going to school in the Inland Empire before leaving California to make my way out to New Orleans, where I went to Xavier University of Louisiana. Shout out XU. and then made my way to New York. I did my East Coast drive for a little bit, and was digging med school out there at New York Medical College before making my way back to LA, where I did the rest of my training at USC. So I did my internal medicine residency as well as my cardiology fellowship at University of Southern California. And then, went on to better places as far as now I'm a practicing physician and doing full-time cardiology with a specialty in sports cardiology. So treating athletes and highly active individuals, trying to keep them safe, trying to keep them healthy, but most importantly, trying to keep them doing the thing that they love.
Okay.
Yeah.
What made you chase that?
Cardiology or sports cardiology?
Sports cardiology.
Sports cardiology specifically. I would say it was the ability to marry two things that I'm really passionate about, right? So obviously cardiology, which I've dedicated my life to doing, right? I mentioned I'm a younger cat, right? Over half of my life has been dedicated to training and getting to where I am, right? So you got to be dedicated and passionate to be able to continue upon that mission. But then realizing that my other passion, which was sports and specifically basketball, was something I grew up playing. You can really mirror the two and combine them because they were individuals, particularly African-American individuals who play basketball, who ended up being the highest risk for problems like sudden cardiac death and things that affect an athlete. And so being able to be in a position where I can treat both was like a perfect marriage for me. So that's really what brought me into it.
Okay.
Sports cardiology, is that a separate fellowship or is that just something you kind of gravitate towards when you look at your cardiology practice? Say, you know what, I want to gravitate towards this.
The initial outlook was that of all the new kind of subspecialties, right? Like in cardiology, we have adult congenital cardiology, right? Where you have children that were born with cardiac defects, right? Congenital defects. And then the technology and the medicine got so good that these kids who didn't used to live very long are now growing into adulthood. And so they needed a whole new specialty called adult congenital cardiology to take care of these kids, right? And so that's a new thing, but they needed to develop a curriculum for it and a board for it. And then you have practicing physicians and they have fellowships throughout the country. Sports cardiology is kind of on that same trajectory. It's really in its infancy, about over a decade old, 10 to 15 years old. And as of right now, there's no dedicated board certification for it. But there are actual core fellowships that are popping up throughout the country. Just a few handful now, but obviously they'll be growing over the next few years. So most individuals who are sports cardiologists right now have gotten into it because of just hours upon hours and years upon years of dedicated training to knowing how to treat this special population of people. And now they are actually developing more formal training for it. And in the next couple of years, I'm sure we're going to see a board certification for it.
I think one of and this definitely when we were younger, one of my first sort of eye-opening experiences with anything sports cardiology related was the whole Len Bias story.
Yeah.
Everybody remembers Len Bias, but nobody was really, it wasn't talked about as like a sports cardiology problem. Right. But that's my first recollection of somebody having a sudden cardiac death while playing a sport. And then, or you'll see, little kids getting thumped in the chest with a baseball in Little League,
Yeah.
And so you'd hear about it, but it wasn't really talked about. And I don't even remember in med school residency it being talked about in the cardiology world. It was just sort of that thing that happens.
Right. It was not.
Yeah.
It was not.
And so I think it's cool now that it's actually becoming this specialty amongst itself.
Right.
Yeah, I think it's pretty fascinating.
And necessary at this point. I mean, it seems like we're seeing more and more. And I think a lot of that comes with the advent of social media where, nothing goes missed nowadays, right? But if something happens, no matter whether it's at a professional stadium like, Damar Hamlin on Monday Night Football or if it's happening. But that was in private though, right? Yeah. That's a practice, right? That when people having like recreational games on at at the playground or whatever, someone's there with a camera and someone's picking this stuff up, or someone's at their little kid's baseball game and the kid gets hit in the chest. There's some parent that was there that was filming, at that moment. So we're seeing it definitely much more in real time, and so it seems like it's happening more frequently. But the incidence actually has not been going up, but we're definitely seeing it more, and people are recognizing that the importance of having someone that can screen for these things, right? Because there are a lot of actual preventative things that we can do to make sure that we are safely having people go out there. We're starting to see that happen more readily. So,
how are you screening kids?
Yeah, good question.
Sports? Yeah,
or
even through every stage.
Older people, yeah.
Because especially, I would think that screening is probably really important for just from the business side of sports.
Right.
People are like, hey, do I want to drop a $100 million contract on this cat? I want to make sure his heart's good. What are you looking for?
Yeah. The way we screen is going to be similar to what, you guys do as orthopedists and sports docs do, which is, history and physical, and trying to find out is there anything that sounds off, with the way that someone is doing the thing that they love. And I think the hard part in cardiology or in sports cardiology is that the defect we're looking for is kind of hidden, right? You don't see it, right? These are athletes. These are elite people who are able to do their activity with no limitation, right?
So it could be something subtle.
It could be something subtle that's not a big deal until it's a big deal, right? If someone has a back injury, you know that right away. They cannot perform, what I mean? Someone has a ankle sprain, we know that immediately, right? They can't hide those defects, those injuries. But someone has hypertrophic cardiomyopathy or a congenital electrical problem or some other genetic disease, they don't know that. And they're playing at their highest level with no limitations and no issues until sometimes it presents as a sudden cardiac arrest.
Yeah, like something has to happen for them to be like, oh, something's wrong with my heart.
Exactly. And so that's why screening is so important, particularly in athletes, because of the fact that they push themselves so much, right? So, both of y'all are in shape. Y'all look a little, yoked when I'm looking at y'all, right? So y'all know.
Hey, it's the black that's slimming.
Is that what it is?
That's why we're black.
That's why we're black. That's why we're black. But look, when y'all are out there,
angle.
you gotta have angles,
catch
right?
the good side,
Angles aren't just for women. You gotta have angles, man.
For everybody.
For sure.
I see you holding your camera with the
in the right way.
You got to do it.
You got to make sure. Look, hey, don't get caught slipping. Don't get caught. Sip on excellence.
Because you will.
Don't slip.
On excellence.
All right, I'm saying. But when y'all are out there and y'all in the gym and y'all are working out, we all know to push ourselves, right? We push. And, that saying, no pain, no gain, right? That's something that's really ingrained within the mentality and the mindset of an athlete.
Culture,
right?
too.
Very, very, right? The problem is that there's sometimes where that pain is a problem. You're pushing through something that's actually wrong. And so it's hard with athletes to actually get that from the history, because we can talk about, do you have chest pain? Do you have shortness of breath? Do you feel nauseous when you're exercising? And an athlete be like, hell yeah.
Do you feel that also elite athletes will not be?
Yeah, I'm going to put it out there.
Yeah,
absolutely.
That's what I said.
Yeah.
Do you feel they lie about it?
Absolutely. Not just
They feel like they have to.
Most athletes that love to play a sport,
correct,
are going to downplay their injuries.
I want to get out there. I want to get out there. My
back doesn't hurt, then they're like this.
Right. It's a little different now in the leagues, though, because them contracts, got people low managing and go ahead and sit down.
They also get those big guarantees.
Exactly.
And so they're okay with
sitting down.
Let me sit my ass down and kind of.
Which, look, we gotta talk about it from a business side who won't be happy about that, from a fan side who won't be happy about that, and then from the athlete side, right? And it's like, I got to play for longevity. I got to make sure that I get that next contract.
Yeah.
Those days of athletes going out there and putting it on the line for the fan experience or for the city that they're playing for, the organization.
Few and far in between that are willing to do that.
Because a lot of people have been played, and they've learned that at the end of the day it's a business. So athletes are saying, okay, it's a business. So that's a whole other conversation.
But it's very real.
It's very real. But my point is that, yes, there are people, though, that are going to downplay symptoms. And so that's, again, it's important to be able to identify who is downplaying something and where is there truly something to be concerned about. But that's why you got to emphasize also, look, you don't want to go ahead and play around with this. You know what I mean?
die.
There's consequences, death. You know what I mean?
Yeah.
So the history is still by far the most important thing, but it's very important on us to make sure that we're clarifying when we're saying, do you have chest pain, shortness of breath, palpitations? Like, what is a palpitation? What is, the dizziness that you're talking about? And then the physical, on exam, we can find a lot of things before we even do any type of testing. We can hear a murmur. We can see people who have features of what's called Marfan syndrome, where someone's like really, really tall, really lanky. They have these connective tissue disorders, which increases the risk of having like aortic dissection and all these things. So we can identify these things just looking at someone and just talking to someone. But then after that,
so those same patients often have scoliosis too, and they'll come to me for scoliosis. And I'll just look at them. They got these long fingers. They're lanky. And I'm like,
You've mentioned it before.
I'm like, before I do anything to your back, I need you to get your heart checked.
Right.
Why do I need to get my heart checked?
Yeah.
Trust me.
Right.
Interesting.
All those patients, no matter how old they are, get their heart and aorta checked.
Exactly. And
They
a
have
lot of
to.
them find that they have a very dilated aorta. The aorta is the big artery in the heart that's pumping blood to the rest of the body. Well, if that artery tears, think of it like a water hose that tears, right? Ain't no water coming out the way it's supposed to if there's a hole in it, right? And that's fatal.
That's a problem.
And so that's one of the things that we have to screen for. And then after we've gone through that part, then yes, there's testing. EKG becomes a very important thing if necessary. Echocardiograms, which is an ultrasound for the heart. And sometimes we do even more advanced imaging, MRIs, CT scans, all of the above. So a lot of different things we can do to try to find a condition. And at the end of the day, sometimes we can't find anything. And the athlete looks stone cold normal on all their testing. And they go out there and they play their sport and they have a sudden cardiac arrest.
Could that just be from a funky electrical malfunction that causes a fatal rhythm or something like that?
Could
and there's
be.
nothing you can detect prior to that.
Yeah.
Your heart just says, I'm gonna short circuit for a second.
It can
That's
be
crazy, right?
It can be a channelopathy, which causes basically where your electrolytes in your heart tissue are off, and then it causes a dangerous arrhythmia. It can be from a structural heart problem that was not seen on the echocardiogram, because we don't get like MRI, CT, all these tests just because. We get it if we see something abnormal, and then it moves us on to the next test. And if something's abnormal here, it moves to the next test, right? Because otherwise we get $1 million workup on every single person, which can be unnecessary. So you end up sometimes missing some of these things if the level of suspicion isn't there. And then again, some of these things can just pop up. Things we can't see if someone has heart disease just on that basic evaluation. We can't see if someone has what's called a myocardial bridge. We can't see if someone has myocarditis. We can't see some of these electrical things, like you mentioned, on the basic screenings. And so these things can go missed.
So here's a question. Why is it that we rarely hear about female athletes having sudden cardiac death?
Yeah.
What is that? Why is that? Does it just not happen, or is it just the nature of what's reported in sports and what we see?
Well, if we talk about the most at-risk populations, women are lower than men, but it definitely happens.
Okay.
I have patients who have had sudden cardiac arrest who are women. We've had, obviously there are a bunch of studies now that are starting to show the outcomes in both men and women. And just like in most medicine, women are not represented in the studies that often, right? Most of the studies are on men. And in sports cardiology, again, like most of the studies are on white men, right? And so we're looking for more diversity within the studies, so we know, okay, who does this data actually apply to? We're looking for more gender variation, so we can say, hey, the screenings that we're doing for men actually also apply for women, right? So that we can say, hey, this is normal in a man, or this is normal in a woman. You can't use the same markers for each one of them. But make no mistake, women do have sudden cardiac arrest. It's a very important thing to identify. It's so important to screen them appropriately. And then again, we know that the disparities exist when women do have sudden cardiac arrest. Sometimes they don't get the appropriate resuscitation efforts because they are women, right? People don't identify it as they are actually arresting. People are scared to do CPR on a woman because of the breast.
Yes, absolutely.
They don't want to expose them. They don't want to get, inappropriate allegations, all of these things. So there are a lot of disparities that exist with women in sports and in sports cardiology that continue to need to be addressed.
Wow. Okay. Wow.
But it
Interesting.
happens. It happens for sure.
But it's funny because you don't hear about it.
No, you
Yeah.
don't.
Yeah.
You are
It's not as prominent.
You are very dialed in. It's all over your face. You are dialed in.
I'm locked in.
What is your mission?
That's a good question. My big interest in sports cardiology is sudden cardiac arrest and health optimization, right? And those two aren't necessarily the same thing, right? When we're talking about health optimization, we're not necessarily talking about the individuals that are suffering from cardiac arrest. But I want to help individuals optimize their health while reducing their risk of sudden cardiac arrest, right? And it takes a lot of different things to be able to do that correctly. My big effort, and something that I've published on and I've spoke about, is really educating athletes specifically about CPR awareness and appropriate use of AEDs, automated external defibrillators, so that they can be part of that resuscitation effort. Because I'm going to ask y'all a question. When an athlete goes down, whether it's on the field, the pitch, the ice, the basketball court, who is it that typically goes out and does CPR for them?
Typically the athletic trainer, right?
Usually the trainer, right? Sometimes there's a doctor on the bench, right?
But who's closest to
who's
them?
closest to them? Their athlete, their teammate, right? And if you go and watch any video, that's the thing that I've been trying to identify, right? I have a study that I published 2023, 2022, something like that, specifically asking that question, looking for different things to help me identify, are athletes even thinking about sudden cardiac arrest? Are athletes concerned about sudden cardiac arrest? Do athletes know what sudden cardiac arrest is? And then do athletes know what to do when sudden cardiac arrest happens to a fellow athlete of theirs, right? And a lot of times the answer is they're not thinking about it, they're not scared about it, and they have no idea what to do.
Sorry.
And so one of the things that I am doing, and my big mission, is trying to improve that response within athletes and that comfort and confidence within athletes so that they can be part of the resuscitation efforts. They need to be part of the first responders.
It actually can build better community,
1,000%.
better teamwork.
1,000%. And not just on the field, but that athlete is now an active responder and a emergency medical servicer in their own home, right? They go home, they're able to resuscitate their parents, God forbid something happens, or their friends, if God forbid something happens. And so making that athlete a center part of someone who is able to perform resuscitation ends up saving countless lives thereafter.
Yeah.
So that's my
because you
big
think
thing.
about, like, on the ice, for instance, all the gear they have on.
Exactly.
Who knows how to get that gear off the fastest?
The person that puts it on every single day, right? And yes, that's just the trainer as well, right? But
still, they have to get there.
They have to come
there.
in. They have to come from the side.
And if somebody's on the 20-yard line down here outside the box, where they have to stand, it's going to take them a while to get there.
Exactly. And what's the most important thing when it comes to resuscitation?
Immediate
Getting their heart
response.
It's immediate response to time, right? We know that survival goes down for every minute that's delayed for CPR. It goes down up to 10% for every minute that's delayed. So by the time someone makes their way out there, assesses, did you just faint, or are you actually down? Or they're tapping them, all this stuff. Their heart is not beating at that point. So there's a lot of downtime, and that can affect the brain and cause other issues. That's why when you look at those videos, go on YouTube and type in sudden cardiac arrest of an athlete, you can see the players freaking out, calling somebody over, pointing at the person, some of them backing away, actually.
Yeah.
And no one is actually getting down and assessing the athlete.
What I've noticed taking care of athletes just from a musculoskeletal standpoint, athletes don't like to talk about injury. They think it's taboo to talk about injury. So when you tell them, hey, here's some things to look out for, how do you teach an athlete to want to learn? Because most of them, like, hey, until I get injured, don't even mention injuries to me. That's what I've noticed.
I think it's tough because it's the type of situation where again, a lot of people think it's not going to happen to me, right? Again, I think with musculoskeletal injuries, I think a lot of athletes know it's something that could and probably will happen to them as they get older if they play long enough, right? But everyone wants to avoid it and whatnot. But sudden cardiac arrest, people are like, that's so rare. It's not going to happen to me. I don't really want to know about that. I don't need to know about it. And if it ever does happen, that very off chance that it happens, okay, we got a trainer. They're going to come and take care of me. So it's a hard thing to try to get them to dial in. And that study that I was doing, trying to assess the awareness of collegiate athletes, that was actually before the Damar Hamlin episode, right? And that was good because there wasn't a bias that was there, right? Because right after DeMar Hamlin, I mean, sudden cardiac arrest was everywhere, right? And then you have multiple people that started having more episodes, and you're starting to see it all over the place. And so it just kind of seemed like it was
or the stories you never hear because, like, for instance, summer training, football players, why are linemen running hills and running mileage and running up and down the bleachers forever?
Yeah.
They don't have to run that far in the game.
Right.
So why are they being conditioned so hard like they're a receiver?
Yeah.
It makes absolutely no sense. And these guys are dropping left and right. There was a program up north. I want to say it was in the Bay or somewhere. They had like a serious problem with the strength conditioning coach. And guys were dropping off left and right.
Just heat stroke and other things like that. Yeah, no, I mean, that's, again, a whole different bag when you're starting to talk about the levels of conditioning and the do's, the don'ts, the kind of the traditional sense of how some coaches used to be, you know, run them ragged, where you have now with kind of some newer approaches to the way people do something.
Drinking oil.
Yeah, no,
to put weight on.
That's crazy.
Drinking oil.
I didn't hear that one.
Right, I'm like, that's kind of wild.
Drinking oil.
Yeah, no, seriously. Drinking oil.
Where was that?
To put weight on. I had a friend played in Arkansas back in the 80s.
Wow.
He's like, he had to put weight on. Coach was like, you got to do this, you got to do this. He was like, dude, I'm about to throw up.
Don't talk about the heart disease that they have later on in life drinking oil.
Drinking oil.
Here's a question for you.
Crazy.
Pivoting from just your sports cardiology practice.
Yeah.
Because I know that's a part of your practice, but not your entire practice.
For sure, yeah.
This being Men's Health Month, I always talk about prostate cancer because of my background and having had it. And so I'm always a big advocate of dudes, go out there and check yourself, especially black men, because we're so conditioned to not go to the doctor until something's wrong.
Right.
What are things that we should be doing as men to make us, number one, not afraid to go to the doctor, let them know it's okay, that we're not going to be cast aside or just brushed off as nothing's wrong if we go say, hey, I need to get checked? And at what age should we really start thinking about our heart health from a, not from just a prevention standpoint, but from a, oh, now it's time to start screening stuff?
Yeah, I mean, we can definitely dive into the why black men specifically don't go to the doctor. And I don't even know if it's so much that they feel that they're going to get brushed off. You know, I think the bigger thing is that a lot of black men don't feel like there's something wrong. You know what I mean? We feel like we're fine. If I'm able to wake up, do what I got to do, I'm still able to walk around. I'm still able to, you know, go to work. I'm still able to have sex. I'm still able to do the things that I feel like I should be able to do as a man, and I'm good, right?
Yeah.
They're not thinking about what's going on internally. Again, this is that concept of chronic diseases often are hidden, right? As opposed to when that man has a bum ankle or a bum knee, you notice that something's wrong, right? Y'all know how we are when we get sick, you know, it's just when a man gets sick, we
get hangnail
right?
and the world is over.
It's over, right? So when there's something physical, that's when we are, you know, looking for help, looking for what medicines or what things we can do. But that is now being reactive, right? And so to answer your question about when should we start going, or when should black men start showing up to the doctor and to go get tested and evaluated, it's before there's an issue. That way you're preventing the issue from ever manifesting, right? So it's early and often. You should do it when you are healthy. You should do it when you are in your 20s and you're not doing it as frequently because thankfully you're more likely more healthy. But as you get older, that frequency might have to increase, especially if you identify something. Yeah. And the beauty of going early and getting screened is that you can catch things that are preventable and reversible, right? Before they hit that level of irreversibility. Right?
And not only that, you can start developing a relationship with that doctor.
Right.
You're going, you know, you're in your 20s, go to the doctor yearly. Just slap my high five, like, check me out.
Exactly. It doesn't have to be a long to do. You know what I mean?
Because at that age, there's not a long to do.
Right.
But as you start to creep up in age and this medication gets tossed in, this medication gets tossed in, oh, I'm 50 or 40, I should start getting my prostate checked. Oh, I should probably get an EKG at some point, even though, you know, whatever that may be. we become scared to find out the answer.
Right.
Yeah.
That's the problem.
Yep.
You know, I hear it all the time. I mean, I see men in my office, and I always ask them, when's the last time you got your prostate checked?
Mm-hmm.
Man, I don't believe in that. Or, I'm not getting a finger stuck in my butt.
Right.
And I'm like, dude, we don't do that no more.
Right.
We don't do that no more, man. It's blood test, dude. Start there. How about that?
Just I think, again, especially in the Black community, the fallacies and myths that are out there are things that are hard to fight, right? Because these things are things that are pervasive in the community, but also in just families and generations, right? It's you know, grandma, grandpa felt this way, and so mom, dad felt this way, so I feel this way, right? And that's a hard thing to shake, right?
The money in the mattress idea.
Exactly. Exactly. No matter how wrong it is ingrained. And so that is the way that it is. But that's also the reason why we have I'm not going to say the reason, that's one of the reasons that we have the type of health outcomes that we do, which is so poor. It's because there are a lot of things that were wronged to Black people in this country and throughout the world. Right? That racism is, again, pervasive throughout the world, and the health outcomes that exist, racial disparities that exist, I should say, are not only in America. It's in other developed countries as well, maybe not to the same degree. But in this country, a big problem is that we take that what was wronged to us, right, and we then still internalize it, and then it's still, sometimes we get in our own way. And so what I try to speak about to my Black patients is, especially when I'm in front of you, I'm like, no, hey, look at me, look here. You can't use that same stuff you use with I'm for you, right? I'm here. I understand the upbringing. I understand that, and this is me speaking as a Black man, right, who grew up in Los Angeles, who, you know, did not come from a wealthy family by any means, who understood the struggle and what it was, and found a way to make a way, right?
Yep.
But with that, had to endure a lot of issues and a lot of problems along the way, right? And so I understand what my patients are going through, where they've been, and not just themselves, where their family members are as well. So when it comes to the things that may be problematic in your households, those things are probably problematic in mine too. You know what I mean?
Right, yeah.
When it comes to things that you've seen in the neighborhood, I saw those in the neighborhood too. You know what I mean? So I think that's an important thing to be able to express to my patients.
Yeah, it's like it's not just family history, it's lineage history.
Absolutely.
It's so scary.
Yeah.
And so real. And we are all experiencing it.
Yep.
I mean, my dad was 3 days shy of going to his physical. Dropped dead. Heart attack. You know, but you know, I brought it up, but he smoked, he drank,
right?
You know,
lifestyle.
worked graveyard shift for 30 years, 40 years. He didn't see the sun.
Right. And let's stay right there. So then you have patients who have a history like your father's, right? And so you're my patient and you come in, right? And there are some people who then believe my dad died of a heart attack. Oh, I was destined, right? My dad had high blood pressure, he had high cholesterol. I'm going to get it too, right?
So I won't go.
What am I doing?
Because it's going to happen anyway.
Exactly. And that's where they do not see the difference between, as you just mentioned, right, that family history and that lineage or lifestyle that's being passed down, right? There's this joke in medicine about diabetes, and people are like, you know, diabetes runs in my family. And it's like, no, diabetes doesn't run in your family. Or no one runs in your family, right? That's the problem, right? That's the issue, right? Yeah. You have a family that does not put an emphasis, a premium, does not place a premium on health, right? On eating healthy and being physically active. And again, there are many reasons for why that happens in the Black community specifically, right? We can talk about food deserts. We can talk about the neighborhoods not being conducive to someone going on an evening walk, right? We can talk about just all these things that make it hard. We can talk about the people that had to work multiple jobs. So when are they going to fit in the exercise? Like, these are all the systemic issues that lead to that. But there's still accountability that we have to make sure that we adopt on our own and not just accept that, hey, this is a genetic problem or a predisposition that I have.
Well, I always think now too, because this is a battle I have with my patients. Obesity. It is.
Oh yeah.
It is. I tell people all the time, there is nothing good that comes from being overweight.
Very true.
I'm like, it makes
it's a taboo topic too. We don't talk about it.
We don't talk about it.
Okay.
Yeah. I tell people all the time, I was like, it makes your life difficult. It makes my job difficult. Because if you're morbidly obese and you have a spinal cord injury, a nerve injury that I have to operate on, you've now made a fairly straightforward surgery infinitely more difficult, which makes your recovery infinitely more difficult.
Right.
I won't operate on you for back pain if you're obese because I know you're not going to get better. No matter what people say, I know you're not going to get better until you lose weight.
Right.
Oh, doc, I can't lose weight because it hurts when I walk or it hurts when.
Yeah.
I'm like, there's simple formulas to losing weight, and don't say just because my family's always been big boned.
Right.
You know,
Big
I'm like your bones.
boned.
I'm like your bones aren't bigger than anybody else's.
Right.
You know, and I try to tell them, I'm like, look, it's not just your back, it's your heart, it's your blood vessels. I'm like, you see the funny colors in your legs? I was like, that's because that blood's not flowing in and out like it should be, and you're 35.
Yeah.
You know, and I'm like, there's a problem, and the biggest problem is people in this country. You can't mention obesity.
Right.
I have every person that comes to my office that's obese, and they ask me, why is my back this way? The first thing they say to me is, and don't tell me I'm fat.
Yeah.
I was like, and my response is, then you already know.
All right.
Now, what do you plan to do about it?
I literally have, I'll never forget this patient in med school. I was in neurology. And we were doing our neurology rotations, and I was seeing a patient, and he came in, and I want to say 45-year-old black guy, very obese. And he, you know, again, I'm very candid with my patients, but, you know, again, this is where that cultural competence comes in, and that cultural concordance comes in, meaning that when it's a black patient sitting in front of you, there's a different relationship, right? Same as if a Chinese patient was seeing a Chinese doctor.
It's the nod.
It's the nod, and there's that level of comfort that goes both ways, right? It's a code switching that we talk about. So, you know, we're very comfortable with each other. And he was like, all right, man, look, doc, you know, I'm a med student at this point. He calls me doc. Man, look, doc, my back's been killing me. My this, my that, man. What's wrong with me? And I don't want to hear that bullshit about my weight. And from that moment, first of all, I couldn't help but just start dying laughing, right? The fact that I was like, first of all, don't talk to me like that. Number two, you already know. Someone has said it before because you're telling me, don't bring that up as the number one thing, right? And so it's so hard to have a foundational conversation without addressing a true problem, right? And what is in a lot of situations and a lot of conditions, the root problem. Now, we can call obesity the root problem of X, Y, and Z disease, right? But there's still a root cause of the obesity, right? Correct. So there's a whole other layer that we still have to then get into, right? And we can talk about the food noises, the behavioral relationships with food, the cardiometabolic issues. There are some genetic tendencies and things that are genetic influences. All of these things certainly do play a role in obesity. But we can't forget about the lifestyle and how that is a big, 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 big factor.
And I tell people all the time when they say, well, genetically, I have this disorder that leads me to being fat or being obese. And I tell them, so change what you can. You can't change what you were born with, but you can change how you live your life according to what you were born with. And they're like, I'm like, your genes don't make you eat.
One of the hardest things, especially being a trainer, is, you know, the conversation about weight. Even as a trainer, they come in to see you. They know they need to lose weight, but they still don't want to have that conversation. And they're always in this mindset that you have to take away. I said, we're not going to take away anything. Let's start adding. Let's add water. Let's add a little more movement, add just a little bit more, because everybody's so told they're always told that you got to take this away. You got to stop doing this. You got to stop doing that. And mentally it shuts them down anyway. So it's like I say, we're not going to take anything away. We're going to start adding and just give you a better mindset wrapped around your daily your living, your projection, your belief system, everything that comes along with that. I think that is the most important. That's important so you can eventually start taking away.
Right.
And they'll start removing because they're like, oh, well, shit, I feel better.
Right.
Oh, I move a little bit more. Because I was even thinking about that after I watched that one post. You was talking about that heavy set guy and how you had to show up for him and he had to show up for you. And then that's what made me think about that. I was like, yeah.
And it oftentimes, again, like that post mentioned, it takes time, right? And it takes multiple conversations, and it takes situations where at times you feel like I'm showing up, and me, when I'm saying you, like me as the provider, I feel like I'm showing up more than you are, right? And the conversations, as I mentioned in that post, they had to change, right? And so I was about to ask you, because what I see in my practice is not a one size fits all, right? And everybody is individual, and we have to individualize medicine, right? And individualize plans and programs and et cetera. So for some people, taking something away off jump might be the solution, right? Yeah. And for others, no, don't touch that. I'll go ahead and I'll try this. I'll try adding that in there, but don't touch this. We're going to keep this here, right? And for somebody else, it's something completely different. And so the hard part, I think, as anybody, all of us who have patients or clients or just individuals who are relying on us to serve or do better for them, we have to determine who is going to benefit from which plan
and how they listen
and how they
That's the hard part. How you deliver that message.
That's the hard part.
And we've said this on this podcast several times. This dude came in. I'm not going to do any deadlifting. I'm not going to pick up any dumbbells. I'm not doing any deadlifting. Rah, rah, rah. All I see are people deadlifting. Rah, rah, rah. I said, okay, sounds good.
Yeah.
All right, no deadlifting. Here, why don't you pick this up?
Yeah.
Shift movements, learn how to build his body balance, see where everything moves, work on his movement, work on his movement, work on his movement. I worked on his movement so much. I said, why don't you go ahead and pick that bar up? It was 315.
Simple.
Picked it off the ground. He said, you asshole. You made me deadlift.
Simple.
Yeah, simple things. Yeah. You don't talk about what they say, I'm not going to. So yeah, we're going to talk about this. But I'm got my hand on your back and we're just going to guide you along the way.
Here's what I come across too, is that conversation about weight is infinitely more difficult with women than men.
Oh, very true. Yeah.
Oh, God, yeah.
I tell you like this, but I'll tell you, it's probably 20-1 pushback, women and men. In my office, if I tell it, like, there's guys who come to my office who look like they're 9 months pregnant and skin, so it's all here.
Right, central obesity.
And they're like, Doc, what do I need to do? I got to get better. What do I need to do? And I'll just tap them on the belly, like, deliver that baby right there, and we're good. But it's that, and they're like, all right, Doc, I got it. You're telling me I'm fat. Yeah, I know I got to lose this. And they'll start tapping their belly. When it's a woman, and if I mention, they're the ones, a man has never said, don't tell me it's my weight. Yeah. It's always a woman that says that. And so you got to do that dance, and I'll do that dance for about 35 seconds. And I just look at them like, all right, here's the deal. Here's all the things you need to do for your back. I was like, but the number one thing you got to do, you got to lose weight. Right. And that's how I finish off the conversation. I can bring it all back, and I'm like, you have to, because it's so much more than just your back. Like when I talk about smoking with patients, they know it affects their lungs, their heart, all this stuff. But when I was like, hey, you smoke, right? They're like, yeah. I was like, do you know that one cigarette causes your disc to degenerate 7 times faster than it would if you didn't smoke? They're like, why? And I was like, it's the nicotine. They're like, why? I was like, well, you know these little blood vessels that feed your disc, after 25, those kind of go away. So these little micronutrients that come from the bone, they get clamped down with nicotine. So you can't even use the patch if you want this back to get better, or if you want your bones to heal, all this stuff. And they're looking at me like this. I was like, you already know your heart and lungs depend on you not smoking. Now I'm telling you, your back depends on it. Right. And for some reason, that clicks a switch. It's like, you're not worried about dying of heart disease, but you want your back to stop hurting. Right. Whatever works. Right. But it's how you tailor the conversation to whatever's going to resonate with them. You know?
No, I think that's tough. I mean, you saw immediately once you said that the conversation is more difficult with women. You have a resounding agreement from both of us. I mean, I think there are reasons for that as well. You know, women are women are held to a completely different societal image standard. Yep. The expectations for a women's body is, you know, outrageous these days, and it gets worse. I mean, it's not even just these days; it's always been that way, right? There's no cover man or no cover boy, right? It's cover girl. It's how this girl looks, how this woman looks, and for that reason, women are always judged immediately by their appearance, unfortunately, and so. That conversation, when you are now coming straight for the way that someone looks, that's going to be harder, I should say, for the woman to accept than it is for the man. Now, again, the conversation needs to be had. And I, too, like you, am always going to get to it, right? And I think one of the things my patients appreciate about me is I'm always keeping 100 with you. I'm always going to be straight up. You can call it blunt. You can call it, you know, direct. But the one thing you for sure going to call it is honest, right? And so I'm very transparent with my patients about what it is, because the ultimate goal is to be healthy. And how we get there is by addressing the issue and then get into where we're trying to get to. But we can't sugarcoat, no pun intended, you know, what's going on.
Yeah, and you have to make people understand, like you said, that lifestyle creates everything. For me, if your sedentary lifestyle damages everything.
Yeah.
Back problems, heart problems, you know, just everything about you. Nobody gets well by sitting around.
1,000%.
You know?
True.
And I think all y'all out there are guilty. And I think these little computers in our hands has made us sit around.
So much more, so much worse.
Oh, it's so bad. And I think y'all need to put this in your ears and walk while you listen to this.
I was going to say, someone's sitting down watching this on their phone, right?
Put this in your ears, stick it in your back pocket, and go for a walk.
Right.
We sound the same, whether it's on Spotify or YouTube.
On YouTube. It's YouTube podcast.
Right.
If you need to go to YouTube, you'll be okay.
That's true. That's true. I mean, I had a conversation with people on, you know, my social media. I did a post on TikTok specifically talking about lifestyles, right? Because that's, again, something that I talk about a lot. And there was someone in the comments that was just, again, there are a lot of people, even on social media, that get defensive even there. They project, you know, what's going on in their personal life. But, you know, people throw in genetics like we talked about, right? And I think this is where there's a term that a lot of people don't realize called epigenetics, right? And epigenetics is essentially, to make it simple, it's talking about how you have genetic problems, right? We all are born with genetic predispositions, whether it's something that's going to lead to this, lead to that, lead to that. But lifestyle and environment and certain types of stressors and different type of things can change our gene makeup and our gene expression, meaning that although I was predisposed to having this disease, I don't have to get that disease unless I give it the fuel that it needs with lifestyle. Right. And so the analogy that you can use is like, we are all pianos and we all have piano keys, right? But what song is played depends on our lifestyle, right? Yeah. Our genes are there. We can't change the piano. It is what it is. Our genes are what they are. But how those genes are expressed, how we play that song depends on our lifestyle. Right. So that's the thing that people really have to try to keep in mind. Right?
I was just thinking, you going to play chopsticks or you going to play Chopin?
What you going to do? It is up to you.
Or Little Richard. Right? I mean, I don't know.
It is up to you, though. The thing is, the choice is yours.
Absolutely.
You know what I mean? So
yeah, I think as we start to wind this down, definitely got to bring you back to go more in depth into some of this stuff. I think it's necessary. A question that we like to ask that we didn't ask in the beginning.
I thought about it.
It's just I think we just dove right in.
Yeah.
But I'm gonna bring it back to it's gonna be about you personally. Mm-hmm. If you couldn't tell me what you do, and you couldn't tell me your name, how would you introduce yourself to me?
If I couldn't tell you what I do or my name, how would I introduce myself?
Who are you?
I mean, the way I'd put it, I'm wouldn't even see. I'm having a hard time saying young these days because I got 3 kids now. I'm like my back be hurting. Like so it's different.
Who are you?
But I've always felt that I'm a highly motivated individual who has a mission to do many different things. I'm the type of person who would say, I don't feel like I'm great in one thing, but I try to be good in a lot of things. And that allows me to be relatable to a lot of individuals and to continue to try to reach the most people as possible to ultimately bring out the biggest thing from each of them. And that's success. And so I do that in a lot of ways, whether it's through the work that I do or through the lives that I touch through that's maybe not as public. But at the end of the day, I'm somebody that's always going to keep going and continuing to make sure that, when I'm out of this place or when my name or when I'm not in the room, my what I do and my legacy is always something that's going to be able to, continue to be talked about.
When this life's journey is done, what's the world what would you want the world to remember, know, or sort of carry on about Doc MJ?
What's your watermark?
Yeah,
what's your stamp, dog?
It might be that at this point I haven't developed that yet, and I think that is somewhat of the beauty of what I'm continuing to do. But if I left at this moment,
I'm not going to let you walk away with that.
I'm gonna definitely say, because it can change, and hopefully it will.
It's supposed to evolve, right?
Exactly. Jay-Z always said, everybody looks at you strange and say you change, like you worked that hard to stay the same, right? I'm not supposed to be in the same place in a few years or in a decade.
Right. But today,
but if I left today, I want people to always recognize that I was a very real, very honest, very straightforward individual with them that always told it to them straight, but always gave them exactly what I thought was best for them. And I think that the legacy that I'm trying to work on right now is being able to leave the right things for my children, my family, but for those people that don't know me at all right now, right? And some of that comes through the mission that you asked me about earlier, which is seeing, what can I do, what type of impact can I make in sports cardiology, specifically amongst Black athletes who at this point are the highest risk and often are not positioned to be able to take care of the right way, and therefore continue to be kind of left behind, despite the fact that they're so involved and so elite in the things that we do. And so I'm trying to address that through the research that I do, through the philanthropy that I do. I have a few different things right now that we work on where we're actually teaching athletes how to perform CPR. And so I want to walk away knowing that if there was one life that I saved by the work that I was doing, that I was done.
And based on everything we discussed today, and this being Men's Health Month, there's one piece of advice that you would give to men when it comes to understanding, recognizing, or just sort of taking their own health into account. What would you say? Where should they start? What should every man at least do this?
Every man should go to their in their home or wherever they have access to a mirror and look at themselves, right? And be honest with yourself. That's step number one, right? That's the accountability that I ask for everybody. You have to be accountable first, because again, if you don't recognize the issue, ain't nobody can help you address it, right? So you have to recognize that issue first. And so for every man that's out there listening, for anybody that knows that they can do better, but doesn't know necessarily the right steps to take to get there, look at yourself and identify what the issue is first and foremost. And then don't be afraid to ask for help to get that issue, whatever it is, right? If you need help here, there, or otherwise, you need to be willing and vulnerable enough to go and ask for it. And I think that's the first thing that I think all men need to be willing and ready to do.
Shit, mic drop.
We out.
Thank you guys for tuning in to another episode of Sippin On Excellence. We try to bring you guys the raw, uncut just in your face real. And it's great to have Doc
We
here.
appreciate you.
I appreciate y'all.
All of our socials, contacts, all of that will be in the bio. And on that note, man, we out.
Yeah. Appreciate
you, man.
Yeah. This was fun.